throat. All right, let me just start by talking briefly on why this talk. So there's some real first sort of obvious reasons that I think many of the people here, or many of us personally, understand the scope and severity of this issue. These statistics are pre-COVID, but when we talk about this triad of looking at, chronic pain and inflammation, trauma, and then also perfectionism, this is affecting a lot of us. Now, the statistics at the top, again, are pre-COVID, but it basically says when it comes to being impaired by a chronic health condition, we're basically looking at 1 in 4 people in our country. So an incredibly, this is us, right? We look around us, it's in our families, it's in our schools, it's in our workplaces, in our homes. And when I say that there are fragmented, simplistic, and harmful systems, I'm not attacking the holistic or the traditional medical system as a whole. What I'm saying is when people present with these complex factors that interplay with each other, they're much more likely to get really problematic care that is can make things much worse. And another reason I felt really drawn to do this talk is because there's a serious sense of gravity. So when we look at suicide risk, the factors that put people more at risk are things like thwarted belonging, entrapment, and burdensomeness. And you can imagine if you're struggling with trauma and a chronic health condition, all 3 of those are certainly impacted. Another thing that drew me to this, to give a little bit of background, is I did my internship in 2007. And at that point in time, my whole mindset was all psychological trauma all the time. I just really wanted to dive in. And in my rotation, you could pick your rotation. And so I selected 2. I selected rehab psychology on a spinal cord injury unit. And then I selected the National Center for PTSD psychological trauma. And so that was sexual trauma and war trauma. And the way that it was structured was these were 2 totally separate clinics in the same institution, 2 totally separate groups of providers, 2 different types of mentalities in terms of the types of interventions that would be used. And then in terms of studies, they were published separate studies. And I found myself wondering, how much does it really matter if the threat is external, like an attacker, versus internal, oh my gosh, the life threat is I can't count on my body when I need to, right? And so that really got me interested in trying to understand more of are we basically inventing the wheel separately in these 2 different disciplines, and how do we bring them together to give more effective consolidation?
There's one for the webinar and I hit unmute, but there's still no sound.
No, not that one.
So it looks like we have one person speaking. Maybe you can chat individually with Margaret and see if she can help out. I will also say I'm recording all this, though I know it's frustrating when the audio is not working. Okay. And then the other thing that really pulled me towards this is that I certainly put myself in this triad, right? You'll hear me give personal examples in here during today's talk. And again, that is not to say that centering and I acknowledge that a lot of the people I work with have experienced things that I've never had to encounter. But there's something called outing yourself in RODBT, and we'll talk about that skill. And it's sort of reducing shame and being able to put yourself out there for connection, right? And then the last thing that really drew me was my clients, and I'll say our clients, because I know we do have a number of providers in here, and then we also have people who are directly interested in the topic because of their own experience, and then a lot of us that are in both of those groups, right? So I would say it is so hard right now, like I mentioned, to get adequate treatment. The demand for healthcare literacy is huge because the systems are so complicated. And I will now more than ever, after about 15 years practicing, I'm spending initial sessions talking to clients about how to, what to prioritize, who to go see. It's a maze, right? And then there's all these different concepts that that get thrown in the mix and are very confusing with different treatments, things like institutional betrayal, medical PTSD, moral injury, health anxiety disorder, chronic pain, inflammation, a disorder of gut-brain interaction, functional disorders, conversion disorders. I mean, I won't bore you with the list, but there's, are we really looking at completely separate and distinct entities? And what happens when someone gets all these different labels? Where do they start? And what do they do? The other thing I'll bring up, which I think is a problem with the medical system, is that when a patient shows up in the room in a hospital, it's not unusual if they're experiencing a stress reaction or they acknowledge anxiety or something psychological, that then gets leveraged and centered as the primary issue. And then there's this sort of either or where they get pushed over into the mental health realm at the expense sometimes of the medical treatment. And again, this binary thing that they should be complementing each other because they're actually not different, right? Nobody draws a neat line here between this and this. Well, we draw the line, but it doesn't exist. Right? I was just having a conversation with a psychiatrist who was saying, well, everybody thinks it's somatic, but I think it might be inflammatory. And I asked this person, like, well, where's the line? Can you explain to me how you define this and this? Because I know procedurally that means you go over here or you go over here. And I don't think the science is that clear that it's separate. And we'll talk more. All right. So jumping forward, why did I pick these two modalities? Well, and also I've color coded it. So we're going to do skills peppered in here. If you see green, that means you're doing erratically open or hearing about an idea from that modality. If you see orange, then it's going to be pain reprocessing therapy. And that might help cue you into what you're drawn to and the ones you don't like. I will say I don't always do the full program with clients, and sometimes I am integrating them together. Okay. All right. Quick disclaimers, and then we're going to jump into it. I'm coming from a particular stance, one that all pain is real. All pain involves the brain, and people do not imagine their pain. So that, to me, is the place we sort of start with. Also, if you're a therapist in the room, both PRT and RODBT have some pretty extensive training, and obviously you're not going to leave here being trained in them. Also, if you're a person who's been struggling with these types of concerns in that triad, I want to name that this is not your fault. And if you hear something today that perhaps you realize, oof, that's not helping me, it's still not your fault. So we're going to watch that if sort of blaming shows up. Also, I am not pro or anti-traditional healthcare. I think the healthcare system is integral. I think it's really good in a lot of different modalities. I've had surgeries that have changed my life. But there are some significant problems too. And then the same about naturopathic or alternative interventions. And my hope then, instead, when for people who are listening and what they could get from treatment, is that patients feel heard about. And that the treatment process would, whether, regardless of the exact modality, reestablishes a sense of trust in your own body and in others. And that there's an informed consent that progress is probably going to be gradual for these types of kind of chronic conditions and fluctuating. I'll also tell you, I'm not like a fanatic about both these trainings. I think there's shortcomings in both, but I think they're also pretty cool. Okay. Of course, I'm not giving specific medical advice today. Pain's multifactorial. It's so important that people rule out structural causes and do not reappraise pain that actually needs some immediate medical intervention. What I mean by that is we can desensitize to pain and we can divert our attention and train ourselves so well. In fact, that you have people who use hypnosis during surgery and require much less anesthetic. But there's a time where we need to feel our pain and we need to get that assessed. I'll also say get curious about certitude. And this is an RODBT concept, but if I say, I'm going to share a lot of opinions. Some of them are probably going to be wrong. Some of them might be really wonderful, whatever wrong is. But But notice when you have some real energy behind something I'm saying, either agreeing or disagreeing. And I'd like to say the same for medical providers, getting curious about when they're so certain, right? I think there's a lot we don't know, even when it's sort of dressed up with MRIs and fancy statistics, which actually don't tell us as much as it might seem. Right? Okay, so today's area of focus, we're going to talk about some of the problematic cycles, go into RODBT. We'll talk about what is pain, which is sort of a fascinating, complex concept, physical and psychological. We'll talk about PRT, and you'll see a video, and then we'll bring it all together and talk about core theories. And the reason I have this warmer, colder thing is because there's a lot of details in here, but I think ultimately, one of the scariest, most overwhelming things when people are dealing with the kind of confluence of psychological extreme distress and physical pain and distress is feeling lost, right? Sometimes not knowing, like, am I about to have a breakthrough here? I'm working something out, or am I about to fall to pieces? And my hope is that you leave here with at least a better kind of gut sense of kind of getting warmer, colder around behaviors and psychological tools that might help. Okay. All right. So I do want to paint a picture for you. I want to talk a little bit about kind of classic dynamics and traits that show up in the therapy room and in the people that I often work with. Okay. So the reason I have chutes and ladders here is because, when someone's presenting, often in my office, there is some psychological distress. There may be longstanding anxiety, depression, PTSD. And that can be a challenge in and of itself for the person in treatment. But the addition of a chronic health concern adds almost a chutes and ladders dynamic, right? Where you can be doing really well, and I'm guessing many of you have played this game at some point, right? You can be having a few really good days, and oh my gosh, all the tools click and it makes sense, and you're confident and you're assertive, and then just slide down that slide and feel like you're back to where you started. And in terms of the way clients will commonly present, I want to run through some sort of typical examples that I see. And these examples, and this is me too, when I've done these things. So when I name some of these observations that I have, I want you just to take a minute and perhaps reflect on what learning history or what situation may have taught them to engage this way. Because, we don't often make things up out of the blue. There's some kind of context, right? It worked in some setting and they're continuing to do it. So many of my clients who come in and sit across from me have incredibly high medical knowledge, right? Well versed, sometimes even more than their practitioner, which can create a dynamic. It's also not uncommon for when these people come in, and I'll say these people out of simplicity, but I'm one of these people. So is that I'll hear an apology about something seeming really small within the first session, right? So there's already kind of like the what we call as an appeasement gesture in RODBT, like, oh, hey, I'm sorry I'm late. I'm sorry I'm not speaking clearly. I'm sorry there's this, I don't want to be a burden. Another trait that I often see when I, start and say, how are you? Is clients with this triad are much more likely after they answer to look at me really authentically and say, how are you? And it's very kind and touching, but it also gets at this idea of a habit of needing to sort of see and be aware of the other person's needs. Another thing is outwardly agreeable, friendly, polite, but also kind of some intrinsic skepticism maybe that doesn't show up. And then sometimes a trait of, I do this like hummingbird. I might be doing it right now. Talking fast, moving fast, when you have the energy before sometimes crashing. And then the last trait I would say is very perceptive and sensitive to their environment. Okay. All right. So when we talk about, let me add one or two. Another one I'd say is valuing harmony, doubting their perceptions. And again, all of these are helpful in some context, but I put this fire here because I almost explain with the metaphor. It's like you did not start the fire, but there may be some things now that you've learned to sort of put logs in that are kind of keeping it going, right? And it's confusing and it's hard and it's counterintuitive. Akin to a fire, right? Where sometimes you can blow out a fire, sometimes blowing on a fire makes it huge. And oftentimes when we're trying to figure out what are the influential variables, one day it's this, but the other day it does the opposite thing. Okay. All right. So when we look at kind of common developmental pathways for chronic pain and illness, and this is an example for functional abdominal pain disorder, you see a typical trajectory. And what that means is there's some early life events, both physical and psychological. So some kind of physical injury, a surgery, an infection, a virus, right? Coupled in the context of high stress. And what we think that means is when you combine high stress with a physical injury that's going to affect your brain's sort of vigilance system, your central nervous system sensitivity. And then you can see as we move across, you notice the onset of some depression, anxiety, more stress. And then those two, the cycle then begins. One begins to feed the other. Right? And one thing I will say is what we know for children when we study trauma in children, and this gets at the idea of big T, little t, is that children, I mean, we might remember this when we're young. Adults are big and scary, right? Children feel small and powerless. So if you have an adult who maybe not doing something capital T traumatic like violence, but regularly yelling at them, and I mean in a chronic way, or regularly so anxious, when you look at the psychophysiology or the physiological data on the children, their hearts are racing. They are experiencing that in a more intense way than perhaps a fellow adult might. Right? Okay. And so it gets at this idea that if you take some kind of physical insult, and then you also take chronic stress in your environment, it can breed the need for perfectionism, this sort of detail-focused processing where you want to prevent and get things right in advance, right? And so when I say perfectionism, I'm not, sometimes clients will say, oh no, I'm not a perfectionist. I mess everything up. And that's not exactly what we're talking about. We're talking about a perspective and a way of interacting with the world where you're holding the reins really tight, where it feels like you have very small margins, right? Not that you're perfect. And when we do that, there is a physiological signature. And I bet many of us, we could probably feel some of it in our bodies now, right? Whether that's our jaw, our back, pelvic muscles. And then we know hormonally and in our immune system. And what that means is there can be this biological wear and tear on our bodies that accumulates over time. And historically speaking, they used to use this term neuroticism, right? And they would link that to cardiac problems. They would also link that to digestive disorders and this diffuse pain. But unfortunately, it was sort of used again to scoot you over to psychiatry or psychology. There was a cool study that was done about 10 years ago that was prospective, as opposed to just looking at the correlation between sensitivity, emotional sensitivity and reactivity to environment and chronic illness. They started and they measured people's sensitivity and reactivity, and then they measured who got a chronic illness over the next 10 years. And that was one of the first studies that really linked and said, no, these things are connected, right? So And one thing I want to also mention with perfectionism, you see this diagram on the right. This is from RODBT. And, perfectionism, I like to say, is sort of the sibling or neighbor of feeling like a complete failure or despair or quitting. So having to do everything right, often then pendulums over to things feeling so overwhelming, exhausted, and impossible. And so in RODBT, one of the skills we're using is identifying, are you in fixed mind, which is that I got to find control, I got to do it, I can't mess up. Have you pendulumed over to fatalistic mind, which is I've tried everything and nothing works. And then what are the tools that can get you in that flexible space? Right. So let's try this real quick. This is an RO scale. Part of RO is about connection, and I'll go through this more, but it's about doing things together. So if you're willing, this is an exercise in imperfection. If you could misspell some word in the chat right now and just notice how that is for you. No judgment, just open up to whatever your body has to say about you doing that. Maybe nothing, maybe a lot. So go throw something in there. Anything that is not accurate, we'll take. I'm not going to put one in there, but I'll just say my favorite one is irregardless. And that's what I would be typing. Okay, lovely. All right. And so what we want to say, though, about this is that this perfectionism and these traits related to conscientiousness and people-pleasing create a private internal vigilance, right? They put the brain on high alert. And it's an allostatic process. And so I think and what we mean by that is that your window of tolerance can move. And so it can feel very, very normal because that your body gets accustomed to it. Right. And, to give an example of that, I was really surprised the first time a therapist mentioned that she thought anxiety was a real problem for me. And because it felt so normal for me. And, one of the processes in RODBT is to sort of be able to look at these complex dynamics that perhaps because we're more sensitive, because we're more perfectionistic, have had excessive shame, and to be able to allow the shame, but also allow compassion, right? And so I'll give you an example about how these can feed each other. So when I was young, I was in competitive soccer, and there was a lot of pressure around, at least internally and probably externally too, that I needed to sort of be the best. And along with that, I'm on the hypermobility spectrum. So I've always, as a kiddo, I always had urinary stress and incontinence. Right? And so what that means is while I'm running around and jumping and sprinting, I felt so much worry and vigilance around do not pee your pants. That will be humiliating. And also you better play very well. And, me 15 years ago would have been far too embarrassed to tell all you wonderful people, this story, because that shame was sort of still alive and driving me. Now I sort of look at it and say, oof, that's wear and tear. That is no wonder. That was a hard situation to sort of be carrying all that at once, right? Okay. So I want to talk a little bit about toxic environments and basically this idea that what's being offered to the patient and what the patient's hoping for are often two very different things. And there's a whole separate talk, and I know many of you are well versed on this idea of the systemic inequalities and how access to healthcare is not only scarce, but it's scarce and unfairly distributed among certain cultural groups, right? That's literally killing certain people, right? By not getting the care they need. And then when we talk about kind of these stereotypes as people are searching for care, there's this expectation of, okay, if I go into a huge institution, I'm going to get interrupted within a few seconds, right? And winning means you get your diagnosis validated with the lab tests and the medical treatment, and you get access. And losing means being told, oof, I don't see this. It might be stress, and then having to go see a mental health provider, which is problematic. And then when we talk about alternative medicines or functional medicine, certainly it's more tailored, there's more hope. But I do think there's sometimes the problematic aspect where all of these supplements and other commercial products are getting sold to people, that puts them on that hope, disappointment roller coaster. And you can see some of this. This was a recent study with Ehlers-Danlos syndrome, and it looked at the impact of negative encounters with clinicians. And the most important part here is the blue. So if you see the blue part, and I won't go through all these, but those, and there's a typo at the top, instead of never for the dark blue, that should mean all the time. But you can see on the right-hand side, these are the problematic experiences where clinicians are overly skeptical of the health complaints related to pain and fatigue. And then clinicians may be less empathic, more dismissive. And then there was a self-doubt and fear of seeking medical attention that showed up. And again, that's not a knock on physicians or psychologists. I think that they're also grappling with some incredibly, their own toxic work environment many times. Okay. I do like this quote, one must ask themselves if obsessive attention to symptoms or precisely optimized self-care will result in better health. The patient has to hold in mind two contradictory modes: insistence on the reality of the disease and resistance to her own catastrophic fears. So kind of outwardly trying to prove herself to these medical providers, while inwardly terrified, if I do have this condition, what does it mean for me, right? And what a struggle. And so in terms of observing cycles, I'm actually, this is a side note, I'll pause. If anyone can guess what movie this is from, I'll know roughly how old you are. Go ahead and throw it in the chat if you know. So what I mean by this is that a lot of medical care is based on a single diagnostic result, right? Or even psychological care. Sometimes it's a quick visit to determine your disposition. And that's wholly incomplete when we talk about how complex the body and mind are. And just as incomplete as someone taking a look at this picture and saying, well, it looks like two focused sailors doing their thing. Now, it's probably in the chat, but this is Jaws, and they're about to have a pretty rough go, right? And so we've got to look dynamically at these, and there are some skills in RODBT and PRT that can do that, right? Okay. And some of the cycles that I want to name that are hard that we do try to unpack are, one, the authenticity versus attachment dilemma. And Gabor Mate talks about this. This idea that ideally we do not have to choose between maintaining a bond with our caregiver and being our authentic selves. Or maybe there's a little bit tension, like I shouldn't slap my mom in the face, but ultimately that we're not trying to hide who we are to remain accepted and cared for. And when people are in this dilemma and do have to get really small, I'll notice that some of these beliefs about their worth feel so true when it starts in childhood. They'll say, I feel it in my bones. Like, I can't imagine acting this way more assertively. I can't imagine getting this need met, because it's just, they've encountered that way of shrinking from such a young age. It becomes intuitive and instinctual, right? I won't go through all of these. I'm an expert at the perfectionism, procrastination, disappointment one. right? Another one I'll highlight is, if you've been trained through your experiences to be accommodating, and you sort of suppress your opinion, stay quiet until you can't take it and you're tearful or you're angry and you've been thinking about it for weeks, maybe months, and then you say something, right? And there's some emotion behind it. What can happen and be misunderstood by others is, oof, she's having a bad day. She's emotional. She hasn't thought this through. But the reality for many of my patients is no. They've been thinking about this for so long, carefully. They were holding it and they needed that ignition of the emotion to prompt them to do it, right? So they're invalidated. And the bottom one, I'll just highlight a poorly titrated exposure to practice to pain. So when people are flooded, which then creates more avoidance, and then flooded again by feeling too much pain, too much out of their comfort zone, and then more avoidance, right? Okay, so I want to show you in RODBT, this is a behavioral chain analysis that's intended to disentangle some of these complex dynamics. And so this is something I'll do with people where you are zooming so closely into the minute by minute, right? Looking at the contributing factors. I didn't sleep well. I felt good yesterday and I felt so guilty not working. So I overdid it yesterday and now I feel terrible again. I ate dairy and oh my gosh, I had really bad gas. And oh my gosh, what if someone hears? What if someone smells? What if, right? And the prompting event is, oh my gosh, in a few hours, I'm supposed to meet my friend to hang out, right? And so then what follows from that? Perhaps anxiety. This thought, can I cancel again? No, I don't have the energy. No, I can't be a flake. And then the mental turmoil. And then you might see links in the chain, right? Where someone then gets distracted, goes online, just works on other projects, waits till the last minute where the fear of being late propels them to approach the scary thing, right? But then you can imagine what that car ride's like. They're like, they're stressed. It's hard to connect and be authentic. Perhaps they're overly agreeable. They don't feel as fluid and as comfortable in their skin. They start to feel sick and they leave early, right? And so these are the types of things then we figure out, where do we intervene and create support. Okay. All right. I do want to say, I think there's just so many beautiful strengths. That's the other side of the coin of people who present with having made it through trauma, having perfectionistic traits, and then having had to confront inescapable suffering of pain you just can't make go away. I don't know if this is a good or bad thing, but I've heard it referred to as nature's shock absorbers. We're kind of getting in there and like, whew, helping keep the system together for good and for bad. Detail focused processing, right? We can really get specific when we need to. Sentinels, we're the ones sort of yelling and screaming and saying, this is not okay. This is a problem. Things need to change because we feel it in our body in a way we can't just ignore. A strong sense of duty and integrity. And so we'll talk a little bit more about that, about this principle-based behavior. And then I call it early onset wisdom. I talk to people who are in their 20s and who have been through some of this. And I'm like, how are you in your 20s? Because your way of seeing the world is so far beyond your years, right? But that does get at the idea of post-traumatic growth, right? And I think this is a complicated concept, right? And Megan O'Rourke says there's a razor thin line between trying to find something usefully redemptive in illness and lying to ourselves about the nature of suffering. And we must mourn what's lost before we can celebrate what's gained. Okay. All right. So what does help look like? We'll talk more about this, but I want to say we can't take all the layers off, but we do talk about the layers of suffering and the ones that we can remove. And it is so counterintuitive. And that's why I put this easy as hard, because when your body is in high alert, vigilant mode, to sort of slow down and treat things with less urgency requires a lot of deliberate mindfulness, right? Okay, so let's jump a little bit more into the treatments. What is RODBT? So it's an evidence-based treatment, and it targets this excessive over control that can arise, where we become more and more careful, rigid, risk averse because of our experiences and our upbringing and genetics to some degree. And it's really focused on creating a life worth sharing, because these things can really isolate us. Even if outwardly we appear to be very well connected, we may still feel very lonely. RODBT is different from DBT, and we'll talk about what that looks like. Okay. Because, although some societies really love over control and view discipline as a good thing, too much of it is a problem. So, for example, it's not that, it's really more this, right? That it's not this linear relationship where more control is just better. And so people who tend to do more, well, let me give you an example. When I went to, I was doing an elimination diet, and I happened to be in Vegas, and I was dealing with some medical problems and trying that route at a period of time. And you can imagine me in Vegas, but I'm at a table, and there's a bachelor party, and then there's a group of men who have come to some boxing event. And when we talk about under control and mood dependent behavior, that's what they're doing. If it feels good, do it. If it doesn't feel good, don't do it, right? And here I am doing rule-based behavior. I may want to eat that, but I can't eat that. I may want to buy that, but I probably shouldn't, right? And so people who do this treatment are often more in rule-based behavior. They have high risk aversion and high inhibitory control. They can be patient. They pass their marshmallow test, right? And I will say it's often not noticed because it's not creating huge problems in society, but that does mean that there can be some silent suffering, right? That shows up. And that's not to say that there isn't emotional leakage, where we do sometimes, but less so. And so access to care is slower. These are the primary targets. But again, the main goal is to get people socially connected, with the idea that humans can go through some really hard things if there's social connection and they have that kind of support, and that loneliness heightens private internal vigilance. It's scary to have a health problem and feel all by yourself, right? Mark, I just realized I haven't paused for a question, but I am looking at the time. Are there any quick, more just clarification questions? I'm not hearing any, so I'll keep going for now, but I'll pause again sooner. Okay. All right. So why radically open? Why is that in the title? There's this idea, of course, you want to change what you can to improve your situation. But in some of these conditions, there's not a cure immediately available to us. And by giving someone skills to be able to endure hard things, that is often just this last bastion of control and sanity, right? Maybe I can't stop the pain, but I can live with it in a way that it's not as aggravated and intense, right? And there's a mentality of welcoming edge states. And so when you look at this levels of acceptance, and you think about perhaps your relationship with an unwanted type of physical or psychological pain, aversion often amplifies it, even though it's so intuitive. And we often, like, I'm very good at tantruming, right? And so sometimes in therapy, we're sort of looking at this scale, seeing how much can you open up somatically, cognitively, and so on. Okay. All right. And so one thing you're doing is you're helping people identify their reaction to environmental cues. And I like to just to show via these puppies, right? So this is autonomic, not conscious responding. And one thing, to do an example, I just noticed how much I'm in goal orienting right now. Just that puppy who's like, come on, I want to teach you all these things. I want to make sure I get through my talk. And what can happen in that place, it's not a bad place, but what can happen is you lose kind of contact with the people around you, and it's not as much a connecting spot. And then also threatening, especially, is a place where in our DBT, there's a lot of skills like the big 3+, where you're trying, and that's sort of an inhale, raising your eyebrows, slowing your vocal tone. You're trying to get a feedback loop to your body. You can see me just do it there of like, hey, we're okay, right? As opposed to the hummingbird feedback loop, right? Okay, there's another cool RO skill. It's called the SAGE skill, and it's basically developed to give you healthy self-doubt and self-criticism, because many people are way too hard on themselves and they have big shame feelings. And so it kind of helps you really figure it out. Did I purposely lie, fabricate, or fail to disclose important information to achieve a goal and benefit myself? So you go through this checklist. Did my behavior damage an important relationship to benefit myself? And what it can do is kind of anchor you back into your values, as opposed to getting flooded by shame and acting from that place. This is a goal and a fun one to do. And then RODBT definitely uses a diary card. Because when we're talking about these complex cycles, we need good data. And we need to know, not your guess what happened a week ago, because that's often not as helpful as knowing what were the true variables in the cycle, so we can begin to unpack it. Right. The other important thing with both of these therapies is something called positive affect induction. Well, we don't take ourselves too seriously. And that's not to minimize the suffering of the client, but it's because taking ourselves too seriously worsens our conditions. And that's what we've had to do. But now, can we practice a little bit of play, a little bit of silliness, right? And so RO uses gentle teases in session, but there's a time and a place, right? If someone is at the top of their distress, probably not a good time to joke, right? Okay. I already talked a little bit about pain reprocessing therapy, but let me just bring up pain first. Okay, so many of you may be familiar with this idea, but our pain experience is very powerfully influenced by our brain's hypothesis about danger. And each one of these circles is an example of that, right? The boot is a construction worker who was taken to an ER shrieking because of a nail that went through. They pulled the boot off. He was in horrible pain. He's a tough guy. It did not touch his tissues, right? Orgasmic birth. I don't know. You can Google that later. Then there's sham surgery studies that have been done, right? Where people who have chronic low back pain, they'll cut them open, do nothing, sew them back up, and it helps their pain, right? So there's subconscious and conscious factors to our pain. And in a way, I think about it, you know, if we give our brain, like, if we're compassionate with our brain, it has to interpret up to 11 million bits of data per second, right? So it's getting huge. And so we've got to selectively ignore some of it, right? Like how this chair feels on my butt, maybe. And our conscious, like mind or dashboard, can only handle about 40 bits of information max. So your brain is constantly figuring out, do I pay attention to this or this or this? And we can harness this to manage how much you're focusing on and strengthening your pain cycles, right? There are generally recognized 3 types of pain. The main thing I'll say about this is that in our medical system, I think there's a hierarchy that shouldn't exist. And I would say that nociceptive pain, like if you can see some tissue or bone damage, people seem to treat that as most valid. Maybe neuropathic second. And then neuroplastic, which is where your brain is having like a trauma response to prior injury or pain, and it's recreating pain, real pain. that seems to be kind of dismissed. But to give you an example, like if you were to get food poisoning, right? Let's say you have bad sushi and then you're vomiting all night. And in the morning, I go and I put a piece of sushi in front of you. What many of us will do is we'll get nauseous. Now, has the contaminated food done anything to our stomach? No. Is the nausea real? Yes. Is the pain and discomfort real? Sort of like a flashback, and that can happen with other injuries and illnesses. So PRT is designed for that purpose. When the pain is mostly neuroplastic, it's sort of this kind of learned pain circuitry as opposed to real, I just said real, that's interesting, but as opposed to structural damage, right, that needs some kind of immediate intervention. Most of the people I work with have a combination. So, if there's a systemic issue like lupus, MCIS, autoimmune condition, they're going to have real pain, and it doesn't rule you out for pain reprocessing. I keep saying real pain. I gotta fix that because that's probably my training and it's wrong. All of it is pain. But there's the pain that fear and anxiety worsens, right? And so that's what we can work with. So I would say, even if it's structural pain or even if it's neuropathic pain or systemic pain, if you have fear and anxiety around it, which most people do, this treatment can help. The evidence is pretty incredible. In fact, they want to see it repeated because it's so incredible. But basically 8 one-hour sessions over 4 weeks. 66% of people who had chronic pain lasting for months, reported they were nearly pain-free. Okay. They have a set of indicators to how to know whether or not it's neuroplastic pain. I don't think it makes it clear. I don't think we can put people in these neat categories, and I think we can get it wrong. But certainly people who have these are more likely to have neuroplastic pain. Okay, so one activity they use in PRT is something called somatic tracking. And I really like this, and I actually think when we talk about disciplines not working, I think the same should apply for psychological trauma treatment. But basically says, if you have physical pain that is a 5 or below, we're going to try to teach you to be with it in a more open, lighthearted, accepting way. We're going to train your brain to apply less of that danger signal over time. And I'll show you an example of this in a moment. If it's over 5, it's a 6 and above, you're going to use your avoidance strategies to cope and make it better. So we're not going to try to be mindful when the pain's too high, because that just reinforces this like tense suffering. Right? Okay, I'm going to show an example. And we'll see, this is an example of somatic tracking where he's trying to be sort of playful with her.
So what I want you to try is just very gently moving. Would it be okay for you to do that? Gently turning your head kind of back and forth from one side to the next like that? Mm-hmm. And is it really painful? Is it a little painful? How painful would you say that is? Like a 3. Like a 3. 3 or 4. All that's happening right now is your brain is interpreting the sensation of moving your neck back and forth as dangerous. I want everyone, all of you guys, I want you guys to turn your heads 20 degrees, 0, 20 degrees. And I want you to bring your attention to the physical sensation in your neck. Do you feel it? Do you feel something in your neck? Of course you do. You're using neck muscles. But the sensation is neutral, right? It's not painful. So all of them are experiencing the same thing in their neck that you are. They all have sensations. The only difference is your brain is interpreting neutral sensations from this area in your body as dangerous. And how does the brain communicate danger? Pain. So Felicia, I just want you to turn your head 20 degrees, 0, 20 degrees, and feel the pain. Let the pain come. But it doesn't matter if the pain comes, because we know that there's nothing wrong with your neck. We don't care about stamping the pain out. All we care about is reframing your understanding of what's actually happening. Your neck is sending the sensations to your brain, and your brain is going, ah, and that's all that the pain is. But this pain is safe. As you keep going like that with your neck, it's just a nice, gentle stretch. And you God, you're only turning your head about 75% as often as the average person, right? So it's, enjoy the fact that you're turning your neck and you're just kind of watching this pain. And you don't need to run from it. You don't need to get rid of it because it doesn't matter that you have it. How are you feeling right now?
I think I want to cry.
Then cry. You're safe. There's nothing wrong with your neck. So, this is just your brain overreacting, and it has perpetuated this feeling of danger, of damage. Let yourself cry.
Okay, so I imagine those of you out there who do deal with chronic pain on a regular basis have some reactions and feelings about this. My hesitation is that he's pretty definitive, right? There's absolutely nothing wrong with your neck. Now, again, I think you have to be very careful saying that, right? There needs to be a very extensive medical workup. But I probably, as a clinician, would shy away from that anyway, because when we look at the history of the medical field, prior to advanced diagnostic testing, you always had to just trust the patient for the most part, right? If it wasn't on the surface, they're reporting something internally and you couldn't get a blood test, right? Or you couldn't get internal imaging. But then something shifted where when you did get access to diagnostic testing, it almost became a requirement. Like if you don't have a positive test, it must not exist. So, again, she seems to be sort of moved and helped by this action. I think if I were doing it, I would probably say it's, you seem to be safe right now, right? Let's take a breath, let's notice it. Because it is likely with chronic pain, we become more efficient in our circuitry and we do amplify it, right? But that must be kind of medically ruled in or out first, right? Okay. So I'd like to summarize and then I'll open it up for questions. So again, when we're talking about pain, we're beginning to see it as an alarm system in these modalities. And that over time, we can get better at discerning what is a threat, how intensely we need to respond and use skills to kind of match it at that level, and adjusting the volume. And for many of us who have come from perhaps challenging upbringings and other difficult circumstances, our threat response is primed and often reacts stronger than it might need to. Not always, right? And that we can find more embodied safety by bringing ease to our behaviors and actions and noticing that just default setting of being amped up. Key feedback loops are important, and this is individualized based upon the client. And there's this idea in RODBT that flexible mind opens us up to full catastrophe living, where the goal is not to get rid of pain, psychological or physical, right? And so we're dropping that struggle, that rope. Sounds a little bit like ACT, but they're, again, similar ideas. None of these interventions are physiologically intuitive for us, easy or quick, I would think, but they're incredibly worthwhile. Okay. And then again, that sense of community matters, right? There's this, in RDBT, we're really trying to help there's the client's social signaling so they can open up, so they can feel safe enough, socially safe enough to form deep, authentic connections and feel less alone. Okay. Here are some resources. I think Margaret, if she hasn't already, she's going to put the link to all of these slides where you can download them. And then one of the things we decided is that we are going to send the recording out to everyone if you came in late, or if there's someone else that you think might benefit from watching. And then otherwise, I will be starting a skills group coming for this triad. So you're welcome to email us if you want to learn more about it. And then I also do consultation with clinicians for some of these complex cases. All right, with that, I'm going to wrap it up and then stop my share and open it up to any questions you might have. Thank you all, by the way, for joining and listening. And
Ashley, there was one question a little bit earlier. I'm just gonna read. Someone was asking